Good morning, QI Talk Timers, and welcome to this morning's pop-up QI Talk Time. We're delighted to have with us Heather Shearer, and she's up at the IAC and speaking there later today. So Heather is going to talk to us about Thinking Up. So Heather is a clinical teaching fellow in St Andrews. She's a QI clinic and a Q member. She also is very much skilled in patient safety, QI and human factors. She works alongside a wide variety of roles of staff, from undergraduates to professionals to managers to very senior managers and indeed board manager level in Scotland, England and Ireland. She's an accredited coach and strength deployment inventory facilitator with a certificate in online learning facilitation, an improvement advisor training at the Institute of Healthcare Improvement in 2008, and a PhD in psychology from the University of Durham. Oh, I need to take a breath after all of those qualifications, Heather. Thank you so much for joining us today. We're delighted to have you. And just some introductions or instructions really for housekeeping for anyone online. We'd be delighted to deal with any questions or comments as we go along. So we'd like to kind of keep it interactive. So there is a bubble at the bottom of your screen that you can press. And we'd be delighted if you have any questions or comments for Heather throughout the webinar, please do press that. And the phone number is in the chat box as well for you there, and it's up on the screen. If you wanted to dial in, please do if the sound is anyway interrupted over the PC. So without further ado, Heather, thank you so much for joining us and look forward to your talk.
Thank you so much, Roisin, and it's a delight to be with you all this morning, bright and early. Certainly the storm wasn't as bad here as I was anticipating, and I'm very pleased that I haven't been trying to fly last night or too early this morning. But it's a delight to be with all you this morning. So I've had the great privilege of working with senior leaders in healthcare for a number of years now, managers, clinicians, executive directors, non-executive directors, chief execs and chairs. So I've done that in small groups, one-to-one conversations, and also at scale with large groups, many people coming together. And there's a bunch of recurring themes that I've come across. And this morning I was going to share with you focus on one of those themes, which is information. So as someone working in healthcare, I have no doubt that you experience a significant volume of paper. You may be partly creating it. I know I have been part of creating this sort of volume of information. If we look at senior level meetings, board meetings or senior quality meetings, it is common for the volume of pages to be around 400 for a meeting, which is a phenomenal amount of text and information that people are being expected to assimilate and make sense of. Of course, we also now present this in electronic form. We use laptops or tablets. Some boards use special iPads that are only for board papers. We might be saving trees doing that, and possibly our backs from carrying all these papers, but it isn't reducing the content or the volume of information that we're expected to deal with. In fact, sometimes it increases the content because it makes it less obvious that we've increased our papers a little bit more, because it's all in that little smart machine that we carry around. So what I've heard repeatedly is that there's this complex relationship between information and anxiety. Senior people in the healthcare system are anxious about the quality and the safety in the services for which they have responsibility. And underpinning that is an anxiety that the papers and the information that they are receiving is missing stuff. I hear people saying frequently, how do I know that what the next issue is going to be? How do I know that the issue that is going to emerge through the press or the media or through a complaint or through a new external inspection report, how do I know that before it happens? How can I be prepared? How do I know that the second level of information, so I may have an audit report that says our services are okay, but you dig underneath that, and the quality of experience is very different for patients. So there's this anxiety that we're missing things as senior leaders. Things are not being contained within these papers. And then there's this belief that more information will increase our certainty. So often we ask for more, we ask more questions, and therefore more papers are produced. And likewise, we may be both asking the questions and also part of providing that additional information. So there's this kind of cycle between, here's a load of information, but I remain anxious about the quality and safety of services. So I'm going to ask some more questions, that information is then provided, but it isn't fundamentally changing my level of anxiety about the quality and safety of service. And there's this underpinning assumption that more information will increase certainty and will reduce anxiety. And the experience of working with people for this number of years is that that doesn't happen in reality. So seeing this and having this conversation with people over years now has caused me to think quite deeply about information and this particular issue. So this morning I was going to focus on 4 aspects of information with you. So volume, like we started to talk about, accuracy, certainty, and interpretation of data. If we look at one example, so let's look at one aspect of quality and safety, say healthcare acquired infections. So a quick look at papers that are presented to senior quality meetings indicates the bombardment of the sorts of information that are presented in relation to this one topic, an important topic, but one topic. So you may see tables of data, you may see text that has numbers in it. In fact, this sentence, and frequently in sentences you see phrases like above and below in the same sentence, or increase and decrease within the same sentence. So lots of text. We see patient stories and staff stories. That's what my little ink men are supposed to illustrate up there. We hear about incidents or read about incidents, themes from incidents, complaints. Sometimes we'll be talking about appointment time, so the length of time that people have in appointments, or the length of stay that people have in hospital beds connected with healthcare acquired infections. We may have targets that are related to this particular topic, and we may be talking about costs. So the costs associated with caring for people who are experiencing healthcare acquired infections. And in some systems and some circumstances, there are fines connected with not meeting targets. So a huge volume of information about one important topic. Often these bits of information aren't connected. The conversation doesn't come together around the quality meeting. Some of this information would be in the productivity or the efficiency report. Others might be in the quality report. So, but this huge morass of information. This isn't the only example where there's a huge volume of information. It also relates to the number of policies or guidelines that we're expected to follow. One study took the example of an older person who's admitted for emergency surgery on a fractured neck of femur. The typical pathway for that person touches 75 clinical pathways or policies or guidelines. And that was only within the acute hospital environment for that patient. So this was a study that was actually conducted in London hospitals, but we know from the comments that underneath the paper in the journal article that rings true for people across the UK, in Ireland, and more widely than that. The volume of policies is enormous. One non-exec director, whose role is to hold the board and the organisation to account, shared with me really honestly their reflections. They had been involved in looking at a patient safety incident where harm was experienced by a patient connected to the cleanliness of the clinical environment, and the clinical environment hadn't been cleaned appropriately between patients. So initially, this non-executive director checked that there was a policy around cleanliness between patients, and yes, there was. We have a policy. My job is done. Actually, it was a member of staff who failed to follow that policy, so they are at fault for the harm that occurred to this patient. This was this senior leader's initial view. However, over time, they came to realise that there were a number of policies that these individual members of staff were expected to follow, which conflicted. So in this particular circumstance, policies around the turnaround time between patients directly conflicted with the policies around cleanliness. So it was impossible for that member of staff to comply both with the cleanliness policy and with the efficiency or productivity policy. And the important reflection and very honest reflection for this senior person was that they had to then sync up. So their job could not be about ascertaining whether or not we had a single policy, but in fact their role was to look at the interactions between policies and to understand how that works in reality for people working with patients every day, and to do something to change that. And that was the conversation that they needed to be having at that senior level. And it was quite an aha moment for that individual about their role, rather than being about compliance with individual policies, thinking about an interaction. So it seems that there's some counterintuitive happening. We're actually losing the connection between reality and the discussions that we have around meeting tables and the decisions that we're making around senior tables. Our discussions in those contexts are only ever representations of reality. All the papers, the presentations that we receive are extractions, they're simplifications of what's really going on. And we inevitably are losing something in those conversations. We then, from that simplified, sometimes sanitized conversations, we're making strategic decisions and making assumptions that may not fully represent the patient experience. So I've been spending a lot of time thinking about this, and I think that part of the explanation for this lies in the way that we work, our cognitive brains, the way our brains are wired to work. And I've got some examples to share with you, and whilst I do that, I'd be delighted if you wanted to share in the chat box how you see some of these things happening in your workplace, and I'll try and weave that into the conversation. Give you a moment just to read this. So hopefully you've been able to make a lot of sense from that. And isn't it astonishing how well our brain is wired to make sense from something that is fundamentally nonsense? And so how often are we doing that? We're making connections, we're making patterns based on the information that we're receiving that may or may not reflect reality. I could show you examples from psychology experiments where I can share with you a list of words, ask you to remember them, maybe stretch your short-term memory a bit by placing a bit of burden on you to remember them. And many of you will add in words to that list that aren't there because they make sense, they match a pattern. We see that in when diagnosis occurs, or certainly misdiagnosis occurs, where a pattern of symptoms, we've pattern matched that to something that we've seen recently, or we've looked at, studied recently, or we're curious about, and we don't pay attention in the same way to the evidence or the symptoms that don't confirm that. So we are wired to pattern match, and it serves us really well in many aspects of our life, but we need to be aware of it because it is a trap that we can fall into when we're working in healthcare. Another aspect that we know from psychology is that it can be, for many of us, really hard to say, I don't know. There are experiments where we offer to people a range of some information and then a series of questions, and statistically, people find it really hard to say, I don't know, when they can't answer that question based on the information that we've given them. Not everybody, but a significant percentage of people really struggle to say, I don't know. And in the conversations I've had with senior leaders, they often reflect that that sometimes feels more difficult the more senior or the more experienced you get. And people say things like, it's my job to know. people are looking to me for an answer. I'll look like I don't know what I'm doing. Those sorts of phrases come up often in quiet conversations. And yet it assumes that it is always possible to know. And in the complex and uncertain world that we're working within, and the very detailed experiences that all of us have as staff and patients, it may not always be possible to know. Quite uncomfortable for us to recognise that sometimes, but it's probably less true than we would like it to be. So saying, I don't know, sharing uncertainty can be a real sign of strength and honesty. So I'm just looking to see if there's any examples coming in on chat. Don't see any yet. But what we've talked about so far are pattern matching, so that ability to make sense from nonsense, that human way of adding information in that might not be there because it fits a pattern that we're expecting. We've talked a little bit about memory strain and placing a burden on your memory. And we've also talked about the confidence to say, I don't know, based on that information we can't know, for example. We also, moving on to think about data in particular and the quality information that we look at in our meetings. So often the data that we look at in meetings is quite old. That's why I've got this picture of looking in the rearview mirror. I know I have produced data for quality committees and been part of them that have reviewed them, and the data is at best 3 months old, often 6 months old. And it's quite a long time in the past. And I think that contributes to some of this anxiety about, but what's happening now? If we're looking at data that's so old, a whole bunch of things will have happened in the last 3 to 6 months. I've also become aware that a number of people are actually really anxious and unconfident about how they analyse data. It's not something that people will often say out loud. They worry it makes them look unfit for the senior role that they're in. I remember years ago now, I had a job where part of my job was to teach statistics on a Masters in Mental Health and Ageing programme, which was a programme for nurses. And my job was to do the statistics bit in that, and people were constantly saying, I don't want to do this, that's why I became a nurse, I didn't want to do data, really anxious about that data side. And more recently, speaking with individual directors, quietly, they will often say, I don't get the data, just don't feel confident about it. And I don't want to say that in a public space because, the doctors will get it. Actually, they don't, because they might say the same thing too. Or the managers will get it. Indeed, the managers often say similar things. So there's this kind of collusion that everyone knows what we're doing about information and data. But when you speak to people individually, they have this uncertainty and they don't feel able to admit it. And it's kind of not surprising. So here's an example. This is a real example I've taken from a quality committee of data that was presented for discussion. So it's about the number of adult support and protection forms that have been raised, so identified by a particular service, issues that relate to adult protection. So looking at this data and watching how the committee responds to this, actually, there was really absent conversation. There was no meaningful conversation about this data. And I think that's because a number of things. So there's loads of lines here. What's the story that this data is telling you? Loads of different lines for different years. There's some numbers that are bolded in the text. There's a sentence at the bottom that has both decrease and increase in the same sentence. So what are you left thinking when you're reading 400 pages of information? Is this decreasing? Is it increasing? And the net result of this is that there is a lack of meaningful conversation around this data. So all the effort that's gone into reading it or preparing it and then reading it, and actually you're not getting the quality conversation. I represented that data using this methodology. This is exactly the same data that's on that slide that I just showed you. And the conversation that you can have changes. So it becomes really visually obvious looking at the data like this that there has been an increase in these forms raised by this service over recent years. So then the conversation became, is that a good thing that we're identifying people? Is it a bad thing that more people are being needed? And I don't have the answer to that, but actually the conversation was happening. Other aspects of the conversation that emerged were, do our staff know how to complete the form? Do we need to support them better to complete the form? What are the implications for productivity or other tasks that our staff should be doing that they're not able to do potentially because they're doing these forms and more of these forms than they used to? And really interestingly, what are we doing with this information into the system? How are we sharing this with our partners elsewhere in the system so they know that there's an increase in the number of adults requiring protection or raising issues? So just by presenting the data differently, the quality of the conversation totally changes. You still have the questions and the answers come from around that table. Here, the informatics skill lies in the creation of this chart and the presentation of it, not in the analysis. And so it frees everyone up to have that important conversation at senior level. So I'm coming to the end of my contribution here really, but saying, I think in summary, what we find is that in our meetings, we talk about work as it's imagined, not work as it's done. So this is a version of a slide that many of you will perhaps have seen that's used to illustrate a number of things about design and reality. So we design policies, we design procedures on the assumption that people will follow the paths and walk on pavements. But actually what happens is that people are taking the short route. They're making their own path across the diagonal. They are managing to balance that relationship between cleanliness and productivity. They're making trade-offs all the time. And if we're not careful, we don't have those conversations in our senior meetings because they're hidden between the bits of paper, they're hidden between the text. And I think our role is to do some of that thinking up and having that conversation. So really, I would hope from this morning's session, I've given you some food for thought about how we deliver, how we receive, what we use information for when we're looking at quality discussions and quality issues. If we had more time together, I'd be inviting you to share with me your experiences, think up what might be your list of things to do differently as a result of some of these conversations. My list may not be your list, but to share with you some of the things that I'm trying to do is I'm constantly trying to look out for the interactions. I'm aware that we pattern match. So I'm looking for the disconfirming evidence. I'm looking for interactions between policies. I'm asking those questions constantly. Thinking out loud is something that I'm doing increasingly often. So trying to spell out my thinking, it can sound a little bit weird sometimes, but by doing so, you're articulating your assumptions and that enables other people to go, oh, but actually, did you know this? Or have you thought about that? Or that set of information patterns matches to something else for me rather than you, and you can have a more transparent conversation about it. I had a boss who was really clear that she would change her mind in the light of new information. And that was her way of trying to think out loud. She worked really hard to think out loud, particularly in one-to-one conversations. She found it more difficult in bigger groups. It's not easy. And actually she was critiqued by others often. They would say things like, I don't know what she thinks, or she's changed her mind, or I don't know where I stand. But given the opportunity to explain what she was doing and her thinking, you've got this much deeper understanding of the issues at hand. So I'd encourage you to think out loud and be brave to do so, even if sometimes people don't react initially brilliantly to that. And of course, go, see, and hear, which I'm sure you all do. Many leaders I've spoken with do go on leadership walkarounds. Sometimes they will honestly say it's starting to feel a bit like a red carpet activity. Everyone's, polished and shined, and I have a checklist of questions that I need to work through that they've seen, and it's all a bit rehearsed. And there is value in leadership walk-around and structured approaches to that. They are also finding that being less formal, just going and being, observing, being quiet in a clinical area and watching can give them a lot greater sense of the authentic nature of what's going on. People have said to me, but they'll never, it won't be the same. As soon as I'm there, people will be different. But we've noticed that if you'd be surprised, regardless of your job title or your role, that if you're just there and quiet, you slip into the background much more quickly than you might expect. And then there's a whole bunch of rich learning that you can then take into your senior meetings. So those are the three things that I'm trying to practice, totally imperfectly. But I would really love to hear from you and hear how you go about trying to do this sort of thinking up, any ideas you get from this morning's session or things you practice and how you get on with that. And if you use Twitter, I'd love to see on Twitter your actions and your learning. So thank you very much for listening. I've kept an eye on chat. I haven't seen anything popping in around examples. Roisin, do board members get training in understanding data? It varies. So there's been a lot of work in England done recently about understanding data and the sort of data that I've talked about, the run chart. And there has been support in Scotland. Not every board member, not every board papers use data in that way, but there has been some training. And indeed, I think you've got some fantastic resources in Ireland that would help you to do the same. Thank you.
Yeah, great. And just the other question around dealing with somebody, you talked about the 80 different processes or policies for the fractured neck of femur. I'm just interested, I know here in Ireland we have talked about testing, having a case manager who would have an overarching view of everything that's going on with the patient. So they connect the physio with the OT, with the nurse, with the doctor. Just, from your experience, do you know if that's worked effectively in the UK? Does it help with that information sharing across teams?
Yes, I think it does, and I have heard of examples of the same sort of thing in Scotland and also in England. And I think that's really valuable for the patient and for the staff around that person. And they have really valuable intelligence because they're the people that spot all of these multiple clinical guidelines or policies. So if we ask them, what are they seeing, that can help us then to understand where we might need to refine or change or adapt or simplify some of our policies and remove some of those interactions. So they'd be a great source of information on that.
Yeah, great. And I know Maureen is in the room with you there. Maureen helped me manage this morning's webinar. If you wanted to say hello, Maureen, and if you have any comments or questions before we finish up, because I know you're rushing off, you're speaking this morning, Heather, at the conference.
Thank you very much, Roisin, and good morning, everybody. I think this is a treasure trove of how we think about information, and really the theme coming from me is giving people confidence to change their practice in how they use information. And I think there's lots for us to think about, so thank you for sharing that. And along with training in using SPC charts and other ways of getting the picture of care, brought to mind is there things that we can do to give people that confidence? And it's an open question. I don't have answers to it. It's just for us as a community to think about.
Yeah, supporting people so that they feel equipped with understanding and being able to read and come up with an outcome from the data that they're reading and an action from that. Yeah. Absolutely. Everybody's very quiet on the chat box this morning. I think everyone needs to go and get a coffee. Heather, I'm going to end the webinar now. So thank you so much for your time and good luck with your talk later on this morning. And maybe we'll get you to come back to QI Talk Time maybe early next year and share some more with us. So thanks very much, Heather. And just if you wanted to flick on to the next slide, Heather, the next QI Talk Time is going to be on the Quality Improvement Team QI Toolkit, which we've just finished and will be going up live on the website very soon, within the next week, hopefully. So this toolkit is based on, I think it's 16 tools, which really should equip staff from, you know, staff on the ground to even line managers and higher levels within organisations with a toolkit that really helps provide a roadmap for quality improvement initiatives from the start and to the end. So we'd be delighted to share that with you on Tuesday the 22nd of October between 1 and 2 p.m. and a flyer and information will be going out very shortly regarding that. So without further ado, we'll end the webinar, and thank you again, Heather and Maureen, and talk to you all soon. Thank you.
Thanks, Roisin.